Hi, my name is Saba Shaikh, and I'm a breast medical oncologist at UT Health San Antonio, and I'm delighted to be joined here by my colleague.
Hi, I'm Aditya Bardia, breast medical oncologist at Massachusetts General Hospital. Excited to be here today and talk about antibody-drug conjugates.
Thank you for joining us. We're very excited to get your thoughts on some of these burning questions. So to start us off, can you tell us a little bit about your interesting study, TROPION-Breast01?
TROPION-Breast01 was a randomized phase 3 global study looking at a TROP2-directed antibody-drug conjugate, datopotamab deruxtecan, versus chemotherapy of physician's choice for patients with endocrine-resistant metastatic breast cancer.
And there's some unique side effects that are associated with Dato-DXd that we don't necessarily see with some of the other ADCs we're using. One of the key ones I'd like to highlight is mucositis. Can you tell us a little bit about what clinicians can do to prevent the risk of mucositis and manage mucositis as we think about potentially using this drug in the foreseeable future?
Yeah, absolutely. TROPION-Breast01 met its primary endpoint. There was improvement in progression-free survival by investigator assessment as well as independent assessment, better response rate as well. But whenever we talk about a drug, we have to talk both about efficacy and toxicity. So 2 points here. First is overall, the incidence of grade 3 or higher AEs was lower with Dato-DXd as compared to standard chemotherapy. And second is, it's not like Dato-DXd does not have side effect. As you were saying, mucositis is the most common side effect seen with Dato-DXd. And the clinical trial, the use of mouthwash was recommended, but not all patients received mouthwash. So we saw mucositis. About 50% of patients in the clinical trial had mucositis. It was mostly grade 1, grade 2. The incidence of grade 3 mucositis was in single digits, but even grade 1, grade 2 mucositis sometimes can be bothersome for patients. So we looked at quality of life results as well. And overall, the quality of life results were in favor of Dato-DXd. The time to deterioration was longer, including looking at the pain domain. But nevertheless, I think we need to implement additional strategies to further reduce the incidence of mucositis with Dato-DXd.
Thank you. That's very important. And one of the other, interestingly, the rate of ILD was actually low in this study. I'm curious to get your thoughts, and this may be a bit of a speculation. How would that rate be impacted if patients were to receive Dato-DXd after another ADC, such as T-DXd, which we know does have a higher rate of ILD?
That's exactly correct. The incidence of pneumonitis with Dato-DXd was much lower as compared to T-DXd. It was about 3% and mostly grade 1, grade 2. So if physicians are using T-DXd and then after that considering Dato-DXd, considering that it's FDA approved in that setting, I think that is a side effect we'll have to watch for besides mucositis.
And that brings me to my next question, which I think is a big question that comes up from a practical standpoint is now we have a few ADCs such as sacituzumab, govitecan, T-DXd, now potentially Dato-DXd in the future. How do we sequence these drugs? What are some clinical considerations you think about?
Yeah, absolutely. That's a hot topic right now. We already have 2 drugs, SG and T-DXd approved, and it's a question we face in clinic every day. And if a third drug gets approved, Dato-DXd, the question would be, how do we sequence? I think many physicians will still consider T-DXd first for patients with HER2-low ER-positive breast cancer, and then at the time of disease progression have a choice of SG versus Dato-DXd. And how would we choose these drugs? Well, if we have biomarkers of response or resistance, we would certainly use that. But if we don't have that, it might boil down to the safety profile. Dato-DXd is given every 3 weeks, does not cause much myelosuppression. On the other hand, SG is given day 1, day 8, causes diarrhea, myelosuppression, but does not cause pneumonitis or cardiovascular toxicity. The rate of mucositis, at least in the ASCENT or TROPiCS-02 trial, mucositis was not seen with sacituzumab govitecan. So it'll boil down to the AE profile, the sequencing, patient preference as we select these drugs. For patients with HER2 IHC 0, at this time, T-DXd is not approved, so there'll be a choice of SG versus Dato-DXd, and I think ultimately, again, will boil down to the safety profile of these agents.
Yeah, we're getting fortunate in that we now have options and we can try to tailor these medications to the individual patient that's coming to our clinic. And so there's so much happening in the ADC space. There's novel drugs, there's new indications being studied, such as the perioperative space, earlier settings in the metastatic setting. I'm curious to hear your thoughts on what are some important considerations we should keep in mind as we further develop ADCs and, look to see what the future of ADCs will be like in breast cancer.
Yeah, as we look to the future, at the end of the day, we should always have a patient-centered approach. So it's about efficacy as well as about the toxicity. And while we are seeing good results with these antibody-drug conjugates, the question is how can we improve that further? And that could either be combinations and also biomarkers where for biomarker selected population, the delta between an antibody-drug conjugate and control arm might be higher. And as we have multiple ADCs, we'll probably need biomarkers for therapy selection. And the other component is toxicity. How can we develop more safer drugs that have lower toxicity, especially as we move these drugs to early breast cancer, which is the curative setting?
Well, thank you very much, Dr. Bardia, for coming today. Congratulations on a wonderful study and a wonderful presentation.
Thank you for having me.